We need an HIV vaccine because although many of the non-vaccine prevention modalities are working relatively well, the idea of having a durable end to the AIDS pandemic will almost certainly depend upon a safe and effective vaccine. Although this is an entirely preventable infection, just the realities of life and circumstances that people are in make it very, very difficult to have a complete turning off of new infections, or to the point where you could have a major impact on the trajectory of the epidemic, the pandemic, since it's a worldwide issue. To have that in the absence of a vaccine and to sustain that in the absence of a vaccine would be extremely difficult.
What are the two main approaches to HIV vaccine development?
The two that are being very actively pursued in human studies. There's a lot of different approaches that are still going on in animal studies. The one is what we call the empiric approach. In other words, take a product that resembles the infection, give it to an individual, even though you don't know what the correlates of protection might be, hoping that you could empirically induce a reasonable response. And then if you get any degree of protection, then try and build upon and improve that. An example of that is the now well-known RV144 trial that was done in 16,000 participants in Thailand, which resulted in a very modest degree of efficacy to the tune of 31%. What's going on right now is a series of studies to try and capitalize on that and to improve it, getting it to be a better breadth, a better power, a better duration.
And that's an NIAID director explaining why we need an HIV vaccine. That's in line with our conversation because, and our conversation is in two parts. Today is World AIDS Vaccine Day. We'll talk about that as well. And I definitely have to also speak to my guest about the HIV, the national HIV prevalence amongst the various groupings. That finding was published, and a lot of people can't believe that the prevalence rates now for 2016 in the Volta region and in the Bnohafu region are really high. What's happening? Dr. Stephen Ayisiado is the National AIDS STI Control Program Manager, Ghana Health Service. Thank you very much, Doc, for your time. Thanks for being here.
Thank you. Good morning.
Yeah, good morning,
to you.
To your
viewers. Yeah.
So on this day, what happens in Ghana?
Well, it's not been a popular day for us as much, I mean, compared to the World AIDS Day, where we celebrate it. But I think as we continue to focus on more things to do with HIV, and as we get closer to successes in, let's say, vaccine development, I'm sure with time it will become a major day.
Okay.
But it's as important as today in the way you've invited me to speak about the issues.
Yeah, we appreciate you being here.
Yeah, so every opportunity is good for us to talk about it.
So with vaccines, what's our situation? Is this easily accessible?
If you're talking about vaccines in general, I mean, fine, but not HIV vaccines. To date, we do not have an HIV vaccine.
Oh, yes.
There is no cure also, but there is treatment.
So I think what I meant was
treatment.
Yes, exactly.
Okay, so antiretrovirals are very accessible now in Ghana, and it's been accessible since 2003, and since then we've enrolled more than 100,000 people on treatment. Not to say that if some people have died in the process, but currently, as at the end of December 31st, we can see that over almost 100,000 people were on therapy.
Yeah. In
Ghana. All right, so we have about 245 antiretroviral therapy sites in Ghana, so where people can go
230?
245.
45 across the country?
Across the country.
Okay.
All the regions where people can go to and then access antiretroviral therapy.
Okay, all right. But we don't have a vaccine.
We don't have a vaccine
yet.
Not in Ghana, not in the world.
There have been attempts.
Yes, there have been attempts to develop vaccines. In fact, since the first case of HIV was identified in 1984 worldwide, in Ghana 1986, it was announced that we'll start vaccine effort to develop vaccines. And we've come through a process. I mean, there are serious milestones from the 80s to date. A lot of new vaccines were tried, and as your viewers saw, the one that came very close to some significant success was in the 2009, study in Thailand. Over 16,000 people were, studied, and we realized that we were able to get something close to a vaccine that could protect people 31% of the time, and 31% is significant, but not, ultimate. So since then, people and other, partners and stakeholders have tried to build on the experience of Thailand. And as we speak now, through the HV, trial network, it has HIV vaccine trial network, an initiative being undertaken in about 25 sites in Africa, United States, Asia, and the Caribbean. We're currently undertaking a vaccine trial in South Africa.
Okay.
And that is building on the experience of the Thailand development to see if we can improve the protection from 31% to maybe beyond 50% or to 60%. That is using one method and approach. But that is not to state that that is the only method.
Yeah.
There are other initiatives going on to see if we can be able to identify a particular, way of protecting people.
But what's the challenge? What's been the challenge? Recently, when the Ebola outbreak came, there were quick efforts to get a vaccine.
Let me state generally that it's not so easy to get vaccines against viruses. Now, but HIV in particular is a unique virus. The way it changes itself, we call it, mutations and here and there. And the structure of the virus makes it a little more difficult to develop just one thing against it. Now, if you notice the way this virus acts and the way it affects the human body, it's not so easy. If you develop a vaccine, if you check the development of vaccines, the main principle is giving somebody something that will generate some protection in the individual naturally to be able to fight with the same thing when it encounters it in future. And the way the retrovirus behaves, in its appearance in people, can have a problem. We have different subtypes also and different, sites. And sometimes when you develop a particular thing against the virus, because of the different structures, it gives a different protection and all that. So currently what is happening is to see if, apart from what's happening in South Africa, if we can develop, let's say, what we call neutralizing antibodies, which will have a wide range of potential to be able to neutralize any form of it. In other words, once it develops the antibodies, in whatever form that the virus presents to the body will be able to fight it.
Okay.
Now, these are all happening, and we hope that if we get that, it will be fine, because to date, there is treatment. Treatment is not cure. HIV is preventable because it's a human behavior thing. We know the modes of transmission. But this particular human behavior is not easy to change and modify. And therefore, until we get something that will protect people from birth or childbirth, from, infants throughout their lives, to protect them, it will be very difficult. We need to, in the process, still continue to educate people and appeal to people to try and modify behavior. But it's not so easy. It's like telling somebody not to eat will be difficult, and you can't develop a vaccine. So sex, and if you talk about sex being the means by which the world is even sustained, procreation takes place and all that, it's not very easy. And most people who may be having sex are not even aware of the potential risks. Apart from people who will be educated and know that there could be the risk of sexually transmitted infections, including HIV. There are many people who do it. Initially, we were all people worry about, let's say, unwanted pregnancy.
Yeah.
But beyond unwanted pregnancy and its socioeconomic impact is HIV, which can deal with the body in a very bad way. And as we are speaking now, a lot of people have become victims. People have died, And
it's interesting how people take measures to prevent pregnancies, but they don't take measures to prevent a sexually infected disease. It's more like the pregnancy is scarier than a disease that you probably don't know whether you will get or not. But is there any research that's currently happening in Ghana?
As far as the vaccine study
Yes.
is concerned, no.
Okay.
No, because, well, if it has to happen within the broad network, then it will be in relation to the others. We have, in the past, I've been part of some studies, clinical trials, where we attempted to use antimicrobicides, to prevent HIV, and in collaboration with Noguchi Memorial Institute. All right, those are all some prevention studies, but when it comes to vaccines, none in Ghana for now.
Prevention studies,
Yeah,
what
so,
does that
so
do?
there are different prevention studies. You know that when you even use condoms, it's prevention. Okay. Now, a study led to we saying that now if you use condoms, it will protect. Now, the antimicrobial study some years ago, in around 2006, 4, 5, thereabout, was looking at how you can give some gel or substance to people before they have sex.
Okay.
So that in case there's a potential risk to transmit HIV, that microbicide would destroy the virus before it's transmitted. It was halted because of the transmission issues and the rate. In Ghana, one of the difficulties of undertaking maybe a study is the low prevalence. If you need to come out with conclusions that will be very solid and justifiable and generalizable, you need a huge sample size, because the rate of transmission, if you take now, even among pregnant women, which is 2.4, it means 100 people, you'll get 2 people. If you take the general population, is 1.6, let's approximate it to 2. So if you want to do a study where
this is small.
It's small, so to be able to get a certain critical amount, to be able to generalize, you need a huge number of people to test and to go through a certain study. And which is why even if there is an interest to undertake a study here, it will be weighed against other countries like South Africa, where
the population is huge.
When population is huge and also prevalence is huge. It's higher, around 20% and all that, so that you can be able to do it. The South Africa study is like about over 5,000 people. The Thailand one was 16,000. So that is why sometimes you lump the countries together. It will not be just one country, because you may not get the same number in one country. So you pick different sites, to do this. And that's why it's sometimes a multi-center, vaccine.
But are we hopeful that we're getting closer to getting a vaccine?
I would say that we have made progress. Since we started this fight against HIV, in fact, in the past, people used to say it was a death sentence.
Yeah.
And then now, if you can take antiretrovirals, and the virus can be undetectable in your blood, as long as you're on the medication. And we found a vaccine 2009, which was 31% protective. We've made significant progress, and there's a lot of work. At the last International AIDS Society conference, a lot of people showcase what they have done, and I'm looking forward to some new things this year, in the next meeting. And hopefully we have made significant progress, and we are getting closer. A few years ago, in fact, I could give it, you get nothing if you are HIV. There was nothing. We were using cotrimoxazole to help people, which is Septrin. Now we have, antiretrovirals. Now we are getting close to some vaccines.
And even the size of the pills have
the
changed.
Size. It used to be a cocktail. Now it's only one. And which is why in pregnancy now, it's easy to give that also. And for elimination of mother-to-child transmission, we're using the same medication.
Okay.
And so our strategy now is looking at how we can take advantage of this. If you say the easily available population that we can reach, apart from the key populations, pregnant people. Because they come to the hospital because of pregnancy, you can test them, and then if they are positive, you give it to them. Because if we are able to prevent mother-to-child transmission, and very soon there will be no person in Ghana who will be born HIV positive. or will get HIV positive become positive in the process of growing up. You get me?
Okay.
And so now those who are already positive are going to grow with it. Once they are on treatment, they can die from any other cause, not AIDS. And then when they all transition out peacefully, we will have a generation that is free, from HIV.
Even though their mothers were.
Even though their mothers were. And today we have a lot of people who are negative, their mothers are positive. And which is why we want to focus on that and make sure that we prevent new infections in children. If you check, they're doing just a little lower than 10% of the total new infections that we are getting are from children 0 to 14. And we need to make sure that we reduce that significantly.
But even that, why is that? Because if there's a test that's carried out very early when the woman is pregnant to ensure that it doesn't transmit to the baby, then why do we still have this figure?
Okay, so different levels of it. First of all, not everybody who is pregnant comes to the hospital. Not everybody who is pregnant and who is even tested and given medication delivers in the hospital. So, so that will create a gap. Not everybody also who even comes, sometimes with health institution barriers. 1 or 2 people may fall through the cracks, may not be identified. Some people also will wait. They will come all right, but will come very late. So even when you intervene, it's too late. And which is why early testing and putting the person on treatment is good. And we are advocating for that. The other thing is to make sure that our antenatal coverage continues to be high. It's high. WHO is even recommending 8 visits instead of 4. More than, we talk about, these days we measure ourselves against 4 visits. But if people come more often, then we can get them and provide these services to them. So as much as possible, there are other factors why you miss one person on the other, non-institutional factors and also institutional factors. And we are trying to deal with all of that. One of the critical things which the Director General talked about is making sure that we really integrate the HIV services. So that, in some places now, you can go have the test. But when you are picked as positive, you have to be referred to the nearest antiretroviral center.
Okay.
And if you have 245 and you have more than 2,000, PMTST sites, the pregnant woman wouldn't go because of transportation issues and all that. So we want to send the medications there so that once they are tested, they can get the medications immediately.
Okay. This recent report of yours, brought out this big revelation that's getting us talking again about HIV with this upsurge in prevalence rate from 2014 to 2016. What's the peculiar thing with the Volta region and the Brong-Ahafo region?
First of all, the peculiar thing was that they were both 1.7 and they both jumped to 2.7. What has happened in the past, before you see even changes in the prevalence, it's due to a lot of activity. Now, because in the past, Eastern region had been a region with high prevalence, Greater Accra and all that, Ashanti, a lot of effort had gone in there. And sometimes even partners want to decide that they are prioritizing their efforts. Because if the problem is small here and it's big here, we will go to where it's relatively bigger. So a lot of effort had gone in working in some of those regions at the expense of the same effort in other regions, which are perceived to be low. It makes sense. Now, so once that happens, you will get the results in those areas. But then those that are more or less not getting the needed attention will also start coming up. And we're noticing that in the patterns. For instance, we know that even the northern regions had lower prevalence compared to the middle before the southern. In this survey, apart from the fact that we noticed that BA and then Volta jumped, Upper West region jumped in prevalence, very high, which is not said. Upper East also increased. It's only northern region that dropped. All right, so even the northern zone, where it were perceived, those zones were perceived to be low prevalence regions, we are noticing that is increasing. And it means that we need to keep a minimum package of service across board. You cannot prioritize only based on some selected regions. we need to sustain the prevention activities and education in all the regions across board. Whilst perhaps based on the magnitude, we'll give more resources relative to some of the regions.
Okay.
Okay, so it's not very simplistic. You can't just say that because it's now that we know that Volta region and Brong and Ahafo have high prevalence. Let's focus all our energy, attention there. Because if you look at the gap, 0.7 to 2.4. Okay, so if it's 0.7 to 2.7, it's narrow. It means Ghana is essentially the same, if you notice. So, and these days, because of easy access, transportation, mobility, and all that, people can access Northern region within 45 minutes. So people are crisscrossing. Ghana is essentially almost the same. If you compare it to other countries, people are traveling, crossing the borders within the shortest possible time. So we have to have a holistic approach.
Okay.
In the past, we were doing a lot of prevention education. We prioritize to do treatment, but we need to link the two and do prevention and then the treatment. And make sure the people who get on treatment are virally suppressed. In fact, that is the thrust of our new strategy as we are moving on.
Okay, all right. I'd like to say thank you to you. I know this will not be the last time that we will speak. We will let you share a lot more things that you're doing with us.
I have to take this opportunity to thank you first of all, and to plead with you all, and to make a case. You notice that we always meet just once, like when this figures come
when
up.
there's a day
All
when,
right, so
when you
which
have a figure
means
out.
that we need to change the approach.
Okay, sure.
So if we can engage more, we expect you to partner with us more.
Okay.
Maybe even on a quarterly basis to project the HIV issues.
Oh, that's absolutely
To
welcome.
let people know that it's still an issue.
Okay.
It's now increasing for the second consecutive time among pregnant women, and we need to be serious about it.
So we will
Thank
come
you
up
very
with a
much.
timetable and have you regularly on our show. That's absolutely fine with us. Dr. Stephen Eisuado, thank you so much for this conversation. Stay with us. Airtel will bring us Becky, who has entertainment here on our show. Stay with us.